So it is my utmost pleasure. I'm so thankful to have you on my podcast. Dr. Doreen Ezeife is a staff medical oncologist at Calgary's own Arthur Child Cancer Center. Did I say that right?
Yes,
Arthur
that's
Child,
correct.
right?
Yes,
Yes.
yes.
Okay. And you did your medical degree at U of T. Where did you do your residency?
I did my residency in Calgary, actually. Yeah. So I
Oh,
met my husband in Toronto when I was in medical school. I was a medical student at the time. And then he was getting a job in Calgary. So I ranked Calgary for internal medicine. So I came to Calgary for internal medicine and
okay.
stayed here for medical oncology because we were all settled here by then. And then
Okay.
went back to Toronto for a fellowship in thoracic oncology and also a master's for about a year and a half, and then
Okay.
came back to Calgary as staff.
Okay. Well, welcome back. We're so blessed to have you, right? And you did your fellow of the Royal College of Physicians and Surgeons in 2014 and then medical oncology in 2017,
Yes, correct.
right? Now
Yes, that's
I
correct.
know that you did a lot of research. What was your research focused on?
Yes, I do clinical research, or health services research. A lot of research looking at health economics, so the cost of cancer care. Also, a lot of health equity research looking at access to cancer treatments, equity and access, like can we access these cancer drugs for all patients or only certain patients with types of cancers? The time it takes to get access to new cancer therapies. A lot of our therapies and immunotherapies and targeted therapies can be very
Mm,
expensive. And when these treatments show efficacy in, landmark clinical trials published in the New England Journal of Medicine, for example.
mm,
Then they get approved in the FDA, and then they're used in the United States, but not yet being used here in Canada. And it takes sometimes
mhm.
years for us to get access to it. So a lot of my research in residency and fellowship showed that time lag that it takes for approval and access to new cancer treatments, depending on where you live in the world. And that really
Mhm.
starts to affect outcomes. People are waiting for these
Absolutely.
novel cancer therapies, and because they don't have access to it, they're being treated with inferior therapies for a long time, and that starts to affect cancer survival. So that's what a lot of my research looks at.
Okay, that's amazing. I love that. Now, I also want to mention that you've got some prestigious awards, including the Novartis Young Canadian Investigator Award, the Canadian Association of Medical Oncologists Fellowship Award, and you received peer-reviewed grant funding from the CIHR, Alberta Cancer Foundation, and Cancer Care Ontario. So that's impressive. Thank you so much, and welcome to the Illuminated Dark Room podcast with me.
Wonderful. I'm happy to be here. It's nice to chat with other doctors, and it's nice to chat about all this stuff. I'm looking forward to it.
Yeah, me too as well. We're going to talk about all sorts of different things, what's oncology, the different kinds of breast cancers, treatment options, new research, and what happens in an oncology visit, and so much more. So to get started, I'm going to ask you, what is an oncologist, and what led you to choose this specialty?
Well, that's great. Yeah. So I always say that there are three different ways to treat cancer. You can either cut it out, you can treat it with medicines, or you can radiate it. So the kind of oncologist that cuts it out is a surgical oncologist. The kind of doctor that radiates it with strong doses of X-ray energy are radiation oncologists, and the kind of doctor that uses medicines is a medical oncologist. So I'm the type of medicine doctor. So I'm a medical oncologist, which means that I use drugs to treat cancer. And I would say that being an oncologist requires compassion. It requires someone to have empathy of people who are going through this period in their life that's the most difficult period that they've ever been through before. And
Hmm.
you're walking them through that period and helping to guide them through that period and guiding them through some of these treatments that can be difficult, but it can also be very gratifying to see them emerge out of this dark time in their life and feel better and recover from the treatments and the disease, and really come out on the other side of that journey. For regarding what led me to go into oncology, oh goodness,
Hmm.
I can remember wanting to be a physician from a very young age. I would say probably under the age of 10. I knew that I
Oh,
wanted to help people in some way that would allow them to heal from whatever ailments they had. And I'm trying to recall what made me want to become a doctor. And I think it started off when I had a friend actually growing up. Um, And he was diagnosed with leukemia, and he was very,
Okay.
very sick, and he required a bone marrow transplant, and he was also another Nigerian man in, Windsor, Ontario, where I grew up, and
Okay.
I remember my sister and I, we got together, and we were actually trying to get our friends and our colleagues and strangers even just to sign up to get their blood tested to see if they were a match for my friend, to see if he could get a bone marrow transplant, because as you know, you
Mhm.
have to be a specific match in order to,
Mhm.
donate. Unfortunately, there's not a lot of Nigerians that are in this database of people who could be potential matches for patients who develop a leukemia or lymphoma and need a transplant.
Hmm.
And we put up signs all over the school. We talked to so many people to try and get him a match. And I
Mhm.
remember thinking, wow, like I want to do this. I want to do more than this someday, where I can actually treat this type of disease, and I want to combat cancer in some way. And then I got a little older and I started undergrad. So I went into biology, biological sciences in University of Windsor, and I started working in a lab. It was a molecular biology lab looking at like tumor polo-like kinases, tumor suppressor genes, and oncogenes. And so it was a very cancer-oriented lab, and that just
Mhm.
fueled my passion even more. And that's pretty much
Interesting.
that period of time where it solidified for me that I wanted to go into oncology. At the time, I had no idea about the three different ways to treat cancer. I just knew I want to treat cancer somehow. I want to heal people somehow, and this is what I want to do. So I started moving towards that path of applying to medical school. And then when I got into medical school, I think I was in first year, and there was this I was in University of Toronto, as you mentioned. And I remember there was this opportunity to apply for summer research like opportunity with an attending physician at
Mhm.
Princess Margaret Hospital, which is a major hospital in Toronto. And I went there and I was all like, bright-eyed and bushy-tailed, and I showed up to the interview, and it was this older gentleman interviewing me, and he kind of asked me, "So what kind of oncologist do you want to be?" I was just hit with a ton of bricks. I must have just looked at him like a deer in headlights, because I had no idea what the different types of cancer doctors were. And I just said, I
Yeah.
want to treat cancer. I'm really interested. And I told him all about my experience in that molecular biology lab and working with tumor suppressor genes and oncogenes. And that he
Right.
actually sat me down and told me all the different types of oncologists. And that was the first time I thought, okay, so this is how I have to delineate what I want to do specifically in medicine.
Yeah,
So
that
that's a
is
little
so
bit of,
interesting. That is really interesting. So basically, you were affected by a childhood friend at
yes,
10. That's actually
yes.
incredible, and that's what
Yeah,
led you to do that. Yeah. Did you have any family in
yeah.
medicine?
I didn't. So my parents are doctors, but they are professors. They're professors. My dad's a professor in mathematics and statistics and physics. My mom is a professor in computer science. So they teach at the university. So they are
Okay.
different types of doctors, but they were very intrigued when we were going into medicine, because they said, you can either be a doctor or a professor or a lawyer, but a professor's great. They was really selling the profession. They think they're, professors. They love the academia, and then when I told
Yeah.
them I wanted to go into medicine, they thought, "Oh, that's interesting. That's very different than what we thought."
Oh, I'm laughing because that's so typical for Nigerians, right? Like you gotta be
Yes.
doctor, XYZ. So I
Professor, lawyer,
exactly. So that is
pharmacist,
exactly engineer,
engineer,
exactly.
yeah.
Yeah, so that is actually quite interesting. Awesome. Well, I'm glad you ended up here because this is very important work that you do. You touched on it a little bit. So you obviously you do undergrad med school and then a residency. How long is the oncology residency?
Yeah, that's a very good question. So the oncology residency after medical school for medical oncology, you go into internal medicine. If you know you want to be a medical oncologist, that's one of the subspecialties of internal medicine, actually. So I went into an internal medicine residency that's 3 years long. So from internal medicine, you can either be a cardiologist, respirologist, nephrologist, audiologist.
Mhm.
Medical oncologist is one of them. So as I went through my internal medicine residency, I knew that I was interested in oncology, but then I really liked the lungs as well. And I was like
Mhm.
just so fascinated by the lungs, the physiology of the lungs, and how it all works, and the anatomy of the heart and the pulmonary arteries and all the structures around the mediastinum. So I narrowed it down to respirology or medical oncology. And
Okay.
eventually I decided on medical oncology. And I guess that's why I'm a thoracic medical oncologist, or why I treat lung cancer as one of the cancers that I treat, or all the above the diaphragm cancers, breast cancer and lung cancer, because I realized
Right.
that this is what I love. But yes, yeah. So it's 3 years of internal medicine,
Okay.
followed by 2 years of medical oncology after that.
Okay.
If you wanna do radiation oncology, it's after medical school, after the 4 years of medical school, it's 5 years of radiation oncology. So you go straight into that, and it's a separate residency program. And then
Okay.
if you wanna do surgical oncology, so I believe that has to be you go through gen surg. So you'll do, like, 3
Right.
years of gen surg, and then from there, there's all the surgical specialties, and surgical oncology would be one of the surgical specialties that you would go into
Mhm.
from gen.
Okay. That you explained that
Yeah.
amazingly. Thank you so much. Now, as an oncologist, do you treat every kind of cancer that there is? Is the expectation that you know about every kind of cancer and treat every kind of cancer, or do you hone in on a certain kind of cancer and treat it?
It depends on where you live. So if you're at a large academic center, like I am,
Mhm.
then because we are also professors at the University of Calgary, we are academic as well. So there's an expectation to do research and administration. So I have leadership roles and teaching because we have a residency program. So we have residents that rotate through us. So I do didactic teaching for the residents, and teaching in clinic for the residents as well. So those other elements, the research, teaching, and admin, are also part of my job portfolio. So because of
Mhm.
that, the clinical, you have only two or so tumor sites that you treat at an academic center. So,
Okay.
or some of my colleagues who are even very very big researchers only have one tumor site that they treat. So, but the majority of us have at least two tumor sites that we treat at an academic center. So all the academic centers, so all the universities across Canada that have oncologists, they usually will only have a couple of tumor sites that they treat because they're
Okay.
so specialized and they do research and teaching and admin. If you're at a community center, so if you're not a medical oncologist or radiation or surgical oncologist in Lethbridge or Medicine Hat or Red Deer or Grand Prairie, for example, the expectation would be that you treat many tumor sites. So usually not all of them, because that would be very difficult. Oncology is changing so much. There's a huge breadth of knowledge that needs to be acquired, and it's constantly changing. We just had our major annual oncology meeting. It's called ASCO, the American Society of Clinical Oncology. So it's our annual meeting that happens around the end of May, early June every year, where all the major oncology breakthroughs come out. They
Right.
are published and released and presented. And that meeting, there's probably like over 300 clinical studies that change the practice of oncology. So it
Mhm.
would be not feasible for an oncologist to be expected to keep up with more than 15 tumor sites. So even at the community centers, so I have colleagues obviously all over Canada that are some of the smaller sites. Because I trained in Toronto, I have lots of colleagues that are practicing in Brampton or practicing in, the smaller GTA areas, Greater Toronto
Mhm.
area
Right.
hospitals, and they treat, I would say, maybe 4 tumor sites. 3, 4, 5 tumor sites would be pushing it. That would be very difficult to keep up with the knowledge, but
Right.
I would say the community oncologists treat maybe 3, 4 tumor sites, whereas the academic oncologists treat 1 to 2 tumor sites.
Okay. Well, that's super good to know. Thank you for that, for explaining that. Okay. Now, cancer care, it's very much a team approach. I don't know if people know this. Can you explain the role of an oncologist in the cancer care team? Like, how do you collaborate with surgeons, radiologists, and other specialties when it comes to treating cancer?
Yeah, so we were talking a bit about this at with rounds. Rounds play a big role. Every tumor site will have its rounds. So here in Calgary, our breast rounds are on Tuesdays, our lung rounds are on Wednesdays. We'll meet weekly to have this multidisciplinary approach where we review difficult cases, cases that are a bit more challenging, maybe cases that don't have as clear cut evidence around the guidance of how to manage them, so that we can review these cases. All of us can ponder it. So at these rounds, there will be medical oncology present, there'll be radiation oncology present, there'll be surgical oncology present, there'll be radiology present, like yourself, Dr. Iffy.
Mm-hmm. Mm-hmm.
Will be for lung rounds, we'll have respirology present. So the doctors that diagnose, they'll be pathologists present as well at these rounds. And this will be an opportunity for all of these types of specialties to weigh in on how they best think this specific case should be managed. And then we all reach a consensus, and there's, sort of a document that we publish or that we create detailing the consensus decision that's been reached. And then that's sort of one major way how we collaborate. I
Mm.
would say that the Arthur Child, our new cancer center, our bright, beautiful building that we've just moved
Yeah.
into just over 6 months ago, really fosters that collaboration as well. I came from Toronto where, they very much had this multi-D approach. At the Princess Margaret Cancer Center, you have these clinics where in the physical clinic, so they would be disease site clinics. So on one floor, there would be a lung clinic. And in that lung clinic, there would be a medical oncology would have a few rooms. There'd be radiation oncology, there'd be surgical oncology. We'd all be practicing in the same space, seeing patients in the same space. So you can just walk over to your surgical oncology friend. Oh, hey, do you think this tumor is big enough? Would you be able to resect this if I give a bit of a chemo first?
Mm.
And then the radiation oncologist comes over. Oh, hey, and then can you radiate these hyalo lymph nodes here? Can you do that? Yeah, yeah, sure, I can do that. After you give chemo and then surgery, okay, and then we come to a decision there. So there was much more collaboration when at
Mhm.
Princess Margaret, and I'm seeing that now that we've moved into the Arthur Child where we're all together, particularly on the breast
Okay.
floor, because at the Arthur Child we have a breast floor on the third floor where we all are situated. We see all of our patients on this floor. So, for example, tomorrow I have my breast clinic, and the surgeon is right next to me. So the surgeons are over
Okay.
there. The radiation oncologist is on the other side of me, and I can just walk over to a radiation oncologist and we discuss and we come up with a plan together on our shared patients.
Okay.
We also have shared office spaces. So all of us have offices on the 10th floor. And we see each other quite a bit and we'll discuss patients. Oh, hey, I sent you that lady. Are you going to be able to radiate her L5? Oh, yeah,
Mm.
sure. I can do that. But are you going to give her some chemo first? And we just sort of discuss that way. So I would say these are the ways that we're able to really facilitate this multi-D discussion. But formal referrals are also another way. If we don't physically see each other, we send formal referrals to each other to weigh in on how best to manage our shared patients.
Oh, I love that.
Yeah.
Because, I obviously, we talk about the rounds, and in my head, I
Yeah.
always thought, okay, that's it. That's your opportunity to collaborate. But in real time, real
Yeah.
life, do you actually get a chance to talk to each other? Patients wonder that. So this is great to know.
Yeah. And I do notice what you were pointing out, Dr. Rafi, that since COVID, things have become much more isolated where we're
Yeah.
not having as much in-person conversation. It's much more paging people now. Like you have to be really intentional, emailing people or paging people or sending a Connect Care message. And then they respond, or, oh, I saw your lady and I was thinking of this and this and this plan. Is that okay with you? Can you resect her after I give her a few rounds of chemo? But so that's kind of how we communicate as well, is electronically. But the in person has been much better since we've all moved into the Arthur Child in the past 6 months, and it's
Oh
been
my
really
goodness,
great.
that's great.
So nice to
That
see
that
people in person.
It
I
totally is,
Oh my
especially in,
goodness.
it's totally an aside, but I used to be at the Cross, and with COVID, obviously the standards are super, super high, right? So even on the radiology floor, we stayed in offices, doors closed, hardly
Oh
saw
my
anybody,
goodness. It's so
and
isolating.
for lunch, yeah, it was so isolating. This is good to know.
I actually get excited. Like the other day, I saw one of the thoracic surgeons in the hallway and I got so excited. I was like, hi, in person. How's it going? What are
Yeah.
your kids? What's up? And he was
Yeah, I
probably like,
know. Okay,
she's
this is
starved
it's
of social interaction, isn't she? And I was like, I am actually.
Oh my goodness, that's awesome. Okay, let's hone in on the breast a bit. Breast cancer. Breast cancer. Breast cancer is the leading cancer diagnosis in women worldwide. We know this, Dr. Doreen, right? We know that it is the most common in women after non-melanoma skin cancer. And we say that 1 in 8 women will be affected. In Alberta, actually, we say 1 in 7. Those are the statistics. What are you seeing in your practice? And I ask you this because, sometimes we look at the data and it's just numbers on a paper. I'm just curious as to what are you seeing in your practice?
I'm seeing exactly those statistics. I mean, I'm obviously biased because all I see is cancer. So I don't see the denominator of that where people who don't have cancer. But the cancer patients that I see are young. I'm seeing diagnoses at younger and younger ages. I would say that 6 years ago, when I first started as a staff attending, it was rare to see a patient under 35 with a
Mhm.
diagnosis of breast cancer. And now I'm seeing it weekly. I'm seeing weekly diagnoses between the ages of 28 and 35. very young people. And these patients are much more complex because often they're young, they're still single women. So
Uh-huh.
they're not married, they don't have children, and it becomes a much more complex discussion for certain types of breast cancer. So if it's a HER2 positive breast cancer, or if it's a triple negative breast cancer, which are actually diagnoses that we see more in visible minorities. So in Black women and in other visible minorities, we see more HER2 positive and triple negative breast cancers, which are the breast cancers that can behave a bit more aggressively. If the tumor is, over 1.5, 2 centimeters, or if there's any lymph node involvement with breast cancer, the cancer tends to spread to the ipsilateral, to the lymph node on the same side, the armpit lymph node on the same side. And so if the disease is either lymph node positive or the tumor is over 1.5 to 2 centimeters in size, then the treatment that's recommended is not removing it up front by a surgeon, not getting a mastectomy or lumpectomy. It's actually coming to see a medical oncologist like myself to talk about chemotherapy before surgery, because this shows that there's improved outcomes with chemotherapy before surgery. So you
So
can imagine.
neoadjuvant, you mean, right? You mean
Neoadjuvant, exactly. So neoadjuvant chemotherapy. And so you can imagine, a young 30-year-old woman who's a single woman. She's maybe working as a waitress or she's in school still. And she's coming to meet a medical oncologist to talk about chemotherapy. And then I have to tell her that chemotherapy can be gonadotoxic. Which means that it's toxic to the ovaries. And so we don't recommend conceiving naturally after receiving chemotherapy. So then it becomes a discussion of going to see the fertility clinic. So we have an oncofertility pathway that we refer these patients to talk about oocyte cryopreservation or embryo cryopreservation if they have a partner. And this is often the point in time where I see tears, where I see the patient get very overwhelmed, the patient get very upset. It's just such a difficult discussion to have, right? But it's the recommendation. And so
uh-huh.
these women are having to go and get these procedures done quickly as well, because usually with neoadjuvant chemotherapy, we need to start within a couple of weeks. It's a very quick thing. You don't want to wait a month because the breast tumor will continue to grow and may spread to the armpit. It may spread somewhere else. So usually these patients are expedited by the fertility doctors and they're seen, and then their eggs or embryos are frozen and then they are back to us to start on their treatment. But I'm seeing also the mental health impacts of that, which are very difficult because it's a very difficult time. It's starting them on these treatments quickly that can be very toxic, and trying to line up the mental health supports can be difficult. We have a psychosocial pathway at the Arthur Child at the Cancer Center, but it's not without its flaws. Sometimes there can be delays in getting these patients seen by psychosocial, and in that time, these patients are suffering with all of the uncertainty and the anxiety that follows a diagnosis like this and all the treatment implications that they're now hearing about. Breast cancer treatment is also a very long journey, and this is something that is not talked about enough. It's a very long journey. It's a journey that carries on for up to 5 years, sometimes 7 years in more aggressive breast cancers. So first, they have either the neoadjuvant chemotherapy followed by surgery, or upfront surgery followed by adjuvant chemotherapy. And then they receive radiation therapy. Sometimes, if it's HER2 positive breast cancer, they're still on these IV antibody treatments for up to a year after their surgery. And then if it's ER and PR positive, so if it's a hormone receptor positive breast cancer, then they have to receive something called endocrine therapy or anti-hormonal therapies after they've completed the really hard stuff, the chemo, the surgery, the radiation. Then they come back to us after the radiation is complete to talk about these endocrine therapies. And what we do is in young women, particularly very young women under the age of 40 with aggressive breast cancers, we have to put their body into menopause, actually. So we induce menopause in these women with injections, subcutaneous injections, to put their body into menopause so that we can then give them aromatase inhibitors, which are medications that reduce the production of estrogen. And this therapy is recommended for 5 years. And so they're on these treatments for a long time, and the survivorship journey is a long one. And then you're seeing all the implications of those treatments, the residual side effects sometimes from their chemotherapies and the surgery and the radiation. But then now the side effects from their endocrine therapy. And usually when patients are on endocrine therapy, then they're transitioning back to their regular lives, right? Because they take time off work for a year and a half to go through the intensive chemo, surgery, radiation. But then after that year, year and a half, many people are trying to go back to work, whether they're a teacher or they're, taekwondo instructor or they're in school. They're trying to go back to that life. They're going back to that life, but also dealing with the side effects of being 35 years old and your body is now in menopause and
Mm-hmm.
all of the menopausal symptoms. And it can be a difficult one, but we do have supports. We have in Alberta here, we have something called the Breast Cancer Supportive Care Services, which are a group of family physicians that help these patients sort of transition through this survivorship journey
Okay.
and psychosocial services as well.
Okay. Yeah, that it's life changing, literally. Like,
Yeah.
you said a lot of things, and I will agree with you that we are seeing just, yeah, definitely way younger, more complex
Yeah.
cases. Cancers are moving quite quickly, right? And
Yes.
why? Everybody's like,
Hmm.
why? I don't know. The answer is right. You,
Yeah.
you mentioned a lot of
I
things,
have a
and
lot of theories.
okay, good. Okay, so we're going to get to that. I'm going to work a little bit backward first with some explanations. Let's start with what kind of breast cancers are there in terms of.
So there are three different types of breast cancer. The first kind is hormone receptor positive, or another name for it is ER and PR positive. ER means estrogen receptor, PR means progesterone receptor. So that's the most common type of breast cancer. Up to 70 to 75% of breast cancers will be this ER, PR positive type in the general population. Now, remember that the general population is very Caucasian. So I would say that in visible minorities, this is not the most common type of breast cancer. The more common type of breast cancer are the HER2 positive kind, which is the second type of breast cancer that we see in about 20 to 25% of breast cancers. And this can behave a bit more aggressively, like I sort of mentioned before. But it's been about 20 years now that we've been using very effective anti-HER2 therapies, which are antibodies that really target that HER2 protein, which is protein that is overexpressed or the breast cancer makes too much of it. And that's what's driving the breast cancer in people who have HER2 positive breast cancer. And so those antibodies have done tremendous things for HER2 positive breast cancer. So with now that we have had access to these anti-HER2 antibodies, the survival has been extremely amazing with HER2 positive breast cancer. And then the third type of breast cancer is triple negative breast cancer. So that means that it doesn't have the ER, PR, or HER2. So you'll see it often also referred to as ER0, PR0, HER2 0, or ER negative, PR negative, HER2 negative. So that's why it's referred to as triple negative, because those three biomarkers are negative. This is the most aggressive type of breast cancer. Fortunately, it's less common. It's quite rare. We only see it in about 5 to 10% of breast cancers. But again, we do see that more in visible minorities.
Okay. Now, thank you for that explanation, Dr. Doreen. What are you looking at to tell you that something is estrogen positive? Is it something you're looking at under the microscope, or how do you know? Is it a stain?
Yeah, so it's a pathological test. So it's a stage that the pathologists do, and they have their ways of classifying and grading it to determine if a breast cancer cell, so a specific cancer cell that they see, is staining a lot of that estrogen receptor. It's a protein, and if they see, so you'll see it reported as either mild, moderate, or high staining, and they can
Mm,
actually give it a grade, so a number between 1 and 8 to determine. So 8 would mean that it's a high staining, and 1 would mean, or 0 would mean that it's no staining, and 1 would mean that it's low or moderate staining. So
mhm.
they give it a grade based on what they actually see on the pathology slide for the estrogen receptor and the progesterone receptor. HER2 is done by a test called immunohistochemistry. So it's a test that looks at the staining, based on the amount of the HER2 protein that is expressed on the cancer cell. And then they can grade that either by 1 plus, which is low staining, 2 plus, which is intermediate, or 3 plus, which is HER2 positive, meaning that the breast cancer cell is making way too much of this HER2 protein or is being overexpressed. If
Uh,
it's 2 plus, then it's somewhere in the middle, and they actually look at the chromosomes to see if the HER2 gene is amplified in that breast cancer cell.
Interesting. Yeah, I always tell patients, I usually take at least 3 to 4 samples, and I say one of them will probably use to
Yeah.
check for bioreceptors to see if it's estrogen or, progesterone positive, negative, right? Yeah. So,
Yeah.
okay.
Oh, you're an interventional radiologist as well. That's great.
Yeah, yeah, I do biopsies as well, yeah, for sure. Yeah. Now, you
Wonderful.
mentioned triple negative cancers. I want to talk about that and HER2 positives because those are, like you said, are more common in visible minorities. We
Mhm.
think of it as it's not as common a cancer, but we see it a lot in racialized women, especially Black women. Why
Yeah.
is that?
Yeah, that's a very good question, and something that I don't think we actually know the answer to fully. We have some hints, it likely has to do with just the genetic makeup, whether there are inheritable genes that we don't know about yet, that we see
Oh,
more that are more clustered in this ethnicity, this population, and they're passed down for generations and generations that predisposes them to these cancers. The other thing we know is a risk factor for breast cancer is elevated body mass index or BMI. And we do see that in racialized women or visible minorities, there may be a higher percentage of women who have an elevated BMI. And that's why we know that diseases like type 2 diabetes and heart disease may be more prevalent in certain racialized groups. So, this elevated BMI that's seen in more likelihood in racialized patients may be another important risk factor for developing certain types of breast cancer. But these are all theories that are postulated, and some epidemiological studies have shown some linkages, but there hasn't been anything definitive yet to show why we're seeing more triple negative breast cancers, more HER2 positive breast cancers in certain ethnicities.
yeah, that's a tough one. And that's why, one of my big missions is to preach advocacy and early detection because really that's
Yeah,
the way, there's
yeah,
nothing that we can do about it. Of course, everybody wants to know why, and we live our
yeah.
lifestyles and we do the best that we can. But if we had the answers, we'd be curing it all, right?
Yeah, it's true. Yeah, I tell people the things we can do are to maintain a healthy BMI. As exercise is showing a lot. There's a lot of data showing that exercise actually combats cancer occurrence and cancer reoccurrence in people who've already had it. So I tell people keep trying to exercise. Yeah, well, a good diet. A low fat
Hmm.
diet. There's now data showing that caloric intake with less than 20% fat is actually linked with less cancer reoccurrence and less cancer occurrence. So I tell people to try and eat a lower fat diet, plant-based diet, minimize or omit alcohol intake, don't smoke. These are all the things we can do. But then there's certain environmental factors that we can't control, like air pollutants and radiation exposure when we take flights or when we just exist in our planet that are not things that we can control, but certainly areas where we can control.
Yeah, we do our best, right? Yeah. Okay. We'll probably come back to lifestyle factors, but what are the different stages of breast cancer? Can you explain it?
Yeah.
0 to 4?
Yeah. Oh, yes. Yeah. So stage 0 is not really breast cancer. So it's a pre-invasive lesion, or another term for it is ductal carcinoma in situ, or DCIS. So you don't really have cancer if you have a stage 0. You have a pre-cancerous lesion that was caught early. So that's fantastic that it was caught early. It's not treated with chemotherapies or anything like that. And then there's stage 1. Stage 1 is usually when the tumor is still quite small, usually less than 1.5 to 2 centimeters, no lymph node involvement, and has great markers, meaning usually ERPR positive, not HER2 or triple negative. Although you can have stage 1 HER2s and triple negatives, but they'll have to be quite small. And then that has a really great prognosis. So stage 1 of the cancers, like actual invasive carcinoma, stage 1 has the best prognosis. And the prognosis reduces as the stages go up, as we would expect. So stage 2 now means that the tumor is larger. There's now perhaps lymph node involvement. Stage 3 means the tumor is even larger. There is certainly lymph node involvement, likely multiple lymph nodes involved. And stage 4 means that the breast cancer has now traveled outside of the breast. So it's metastasized, which the word metastasize just means that it's spread outside of the breast to usually neighboring organs. So the most common would be the chest wall or the bones or the lungs, really metastasize anywhere in the body. So the liver, the kidneys, or the brain in some cases. And stage 4 breast cancer is associated with the poorest prognosis because it's no longer curable, meaning none of our treatments can eradicate it or make it go away completely. They're only aimed to control the cancer, to help extend the patient's life and improve their quality of life. So, but we know we have a lot of great treatments for stage 4 breast cancer or metastatic breast cancer. And I have patients who have been living for years, 6 years, more than 6 years with metastatic stage 4 breast cancer. So we have, and these are HER2 positive metastatic stage 4 breast cancer who've been living for over 6 years. So we can have a lot of great outcomes if people accept treatments and their body's able to tolerate the treatments and their cancer responds to the treatments. People can live for a long time.
Okay. So someone says to you, "Well, why do I need to get a mammogram if, well, you could have metastatic breast cancer and you can live a long time. So what's the point of doing the mammograms and going every year and getting the radiation and the compression?"
Yeah, I would say that, living with stage 4 breast cancer, living a long time is not guaranteed. Um, when you have a diagnosis of stage 4 breast cancer, the survival is quite limited in the average patients. The best treatment would be to catch the cancer early, and that would result in the best outcomes because when you catch it early, then you're most likely to be able to cure it by removing it surgically or and giving supplementing that with chemotherapies and radiation to eradicate the cancer and make it go away. So you'd be free from it, hopefully forever. So catching it early saves lives. It allows you to ensure long-term survival. Whereas if it's caught late, then you may not necessarily survive that.
Yeah, that's a great answer, Dr. Doreen. I know, early detection, we talk about that DCIS, but like you mentioned, it's not really breast cancer, right? It's a
Mhm.
pre-cancer,
It's a
even though we do
precancerous
say it's
lesion.
breast. Exactly, right.
Yes.
Awesome.
Yeah.
That's amazing. I'm glad that you talked about that. The lower the stage, the better the prognosis. Early
Yes,
detection.
exactly. Early
Right.
detection is key. Please get your
Absolutely.
mammograms.
Yes, absolutely. And another thing that we do see is people come and they don't want the mammograms. Some people they want an ultrasound, and I try to explain to them we don't see those calcifications for that DCIS on ultrasound, and so you're
Yeah.
missing the opportunity for us to find it before it actually becomes a cancer. It's such
Yes.
it's difficult for people to fully understand that, sometimes.
Yes.
So
Yeah.
that's why I
Yeah,
love
and
your
mammograms are
explanation.
also standardized for screening. So there's a whole
Yeah.
process to use mammograms for screening, whereas ultrasounds are not. So
Mm.
the best data is using mammograms for screening. I know people tend to worry about the radiation associated with mammograms, and they think, ultrasounds don't have as much any radiation really. And why do I have to expose myself to the radiation of mammograms? But the risk of exposure to radiation is so low.
So little.
The benefit of potentially catching precancerous or small cancerous lesion is so much higher.
Absolutely. Absolutely.
Mhm.
Okay, awesome. Now, we talked about therapies before, and I'm going to try and list some, and then maybe we can, talk about them one at a time. You talked about chemotherapy, there's radiation therapy, immunotherapy, endocrine therapy, targeted therapy, surgery. You mentioned a lot of things. So, how are these chosen? Would it be better to talk about how these are chosen first, or should we just kind of go by? Let's go with chemotherapy.
Okay.
Do you choose who gets chemotherapy? I picked this one first because I don't know if you saw or listened to Ananda Lewis. She was a video
Okay.
VJ at the time, and
Okay.
she's a black woman, very popular. She's a celebrity. She ended up with
Yes, Amanda Lewis. She was on like the Real or something at one point in time, and she's very vocal, very outspoken. Yes.
Yeah, and then she mentioned, she was talking about her cancer. Her mom had breast cancer, but when she was diagnosed with breast cancer, she chose to keep her tumor. Now she talks about she was told that she had all these options for chemotherapy, and the oncologist chose like the third from the bottom. And I'm thinking to myself, how do you as an oncologist decide? You look at a patient and you're like, here's options 1 to 10, but I'm going to give you number 7. So can you kind of address that? How do you decide what chemotherapy to give? Is it IV? Is it oral? What's that whole process like?
There's actually not a lot of decision making. It's all standardized protocols that we use based on international clinical trials that demonstrated efficacy of the protocols that we're using. So there are not 10 options. I don't know about Amanda Lewis referring about the 10 options, but in a specific type of breast cancer and stage of breast cancer, there will only be like one or two options. And we will have data that demonstrates the superiority of one of those options over the other. Sometimes there'll be that equipoise. And in those situations, that's where we're presented at rounds, where there's
Mhm.
data showing option A is great, and also data showing option B is great. And then we'll present it at rounds and reach a consensus where 20 of us docs will meet and we'll reach a consensus as to what the best option is. But all of us pretty much have a standardized approach on what chemotherapy to select for a specific patient. So, for example, let me give you an example. So, let's say I have a 42-year-old woman with a 2 centimeter right breast cancer. So the tumor is 2 centimeters in size, and it traveled to one out of three sentinel lymph nodes that were resected. There was some extranodal extension seen. There was lymphovascular invasion present. What else can I tell you about it? It was ER strongly positive, 8 out of 8. PR strongly positive, 8 out of 8.
Mhm.
HER negative, 1+, or HER2 low, 1+. So
Mhm.
so that's sort of her profile. She's coming to see me in clinic. She's post surgery. So her tumor's been resected. That's how I have all those details on her surgical pathology.
Mhm.
And she's coming to see me in clinic about what to do next. So she's 42 years old, meaning that she is premenopausal. So she's still having periods. Her last menstrual period was like 2 weeks ago. So she's
Mhm.
premenopausal. And the premenopausal patient, there's actually a clinical study showing that chemotherapy in node positive premenopausal patients is recommended because it decreases the risk of recurrence and improves survival. So in this patient, I would recommend chemotherapy. Now, the question of what type of chemotherapy would I recommend? So there are two options and protocols. You can either have an anthracycline including protocol or a protocol with no anthracycline. So anthracycline is a type of chemotherapy, a drug like doxorubicin or epirubicin. They are chemotherapy drugs that have decades worth of data demonstrating their efficacy in breast cancer. So the most effective two chemotherapies in breast cancer are anthracyclines and taxanes. So when you read the breast cancer literature, you'll see anthracycline, taxanes. We have
Mhm.
40, 50 years of data showing us these chemo drugs work well to kill breast cancers. Breast cancers do not like anthracyclines and they do not like taxanes. So if you want to kill a breast cancer, use anthracyclines and taxanes. So this woman is seeing me. She's seeing me because there may be micrometastases that nobody can see, no scans can see. And the role of chemotherapy is to kill off those micrometastases to prevent the cancer from coming back, to prevent a reoccurrence. And now, because of her pathological features, because she's lymph node positive, that puts her in a higher risk category. So when I see a
Mhm.
lymph node positive patient, I know that I need to recommend an anthracycline containing protocol. If they're a lymph node negative, I would recommend something without an anthracycline because anthracyclines can carry their long-term side effects as well.
Mhm.
So if they were lymph node negative, she wouldn't need an anthracycline necessarily because she's got a lower risk tumor and doesn't need an anthracycline. Now, she's lymph node positive and she's premenopausal, so she needs an anthracycline. What we typically use is something called dose dense ACT or dose dense. The A stands for adriamycin, which is the brand name of doxorubicin, which is a scientific name.
Mhm.
C stands for cyclophosphamide. I tell patients these are just acronyms
Mhm.
for the name of the chemotherapy protocol. C stands for cyclophosphamide, and T stands for the taxane or paclitaxel. So that's
Mhm.
the regimen that I would recommend. That's the regimen that, like, if you go to ChatGPT or there's like these oncologists online. If you go to any of the oncologists and you give them these pathological features I just gave you, they would say ACT would be the recommendation. There's a body of data also showing that a dose dense protocol, which means that it's given every 2 weeks instead of every 3 weeks, dose dense is superior to giving the chemo every 3 weeks because it results in about a 20% improvement in overall survival. So we have
Mhm.
established randomized controlled trials, meaning level one evidence, demonstrating the efficacy of these chemotherapy protocols, how they're given, what doses are given, what drugs are given, decades worth of data. And that's why we make these recommendations. We don't give people, these are 10 options. That never happens. I think sometimes when celebrities, I hear these things in the news, I roll my eyes because I know that it's like a game of telephone. Like it's a bad game of
Yeah.
telephone where she probably heard one thing or she probably changed the story or I don't know exactly what happened, but it would not be sort of 10 different options. There are actually very few options because these are very controlled protocols based on a body of evidence,
Mhm.
level one evidence that established their efficacy in this disease. So for a specific type of tumor, a specific stage, it would be specific protocols that are recommended.
Yeah, thank you. I asked you that intentionally because, it's like you said, sometimes when celebrities say things, people tend to believe. It's like it's like Bible. They've
It
said it
carries much more weight than if
very
a
much.
random doctor says it, despite the
Absolutely.
years of education.
Exactly. And that's why I had actually done a podcast with a friend on this. And I said we've got to be when we are in a certain position, we have to be careful what we put out there and make
Yeah,
sure that it's accurate. And for
yeah,
me, as a black woman, and especially how it affects us, and these what she said, these went into Essence magazines, our Essence, you know, magazine. And this is not good. She made a lot of
it's
great points, but I just thought it's really important to make sure that the facts are right when you're saying
it
things
spreads that
like that,
misinformation.
right?
That's why we need educated people like you and I who
Yeah,
have our MDs, have our masters, have the education backing us to be able to understand the literature, to
right.
explain these things to lay people who don't understand the literature and are more attracted to believing what a celebrity, a public figure says, who doesn't have the
Absolutely.
education, doesn't have the knowledge.
No, no, absolutely. Or who has spent thousands and she spent thousands and I mean thousands and thousands of US dollars on alternative therapies that, I know I certainly can't, a lot of people can't afford, right?
Yeah,
And at the end of the day, she
yeah,
still has to go back to conventional therapy, right? So
yeah,
okay,
yeah.
well, thank you for that. Well, you talked about neoadjuvant chemotherapy. I've always wondered, well, if you start somebody on neoadjuvant chemotherapy, which means chemotherapy before surgery, right? Is
Mhm.
there a specific time frame where you have to check to see if it's working?
Yes, I usually check halfway through the regimen. So the regimen takes about 4.5 months to get through, four and a
Okay,
half to 5 months to complete the protocol, because most of our neoadjuvant treatments, the most commonly given neoadjuvant protocol is given every 2 weeks for 8 cycles. So that takes about 18 weeks or 4.5 months to get through and halfway through. So it'll be dose dense ACT. Now, you could be a medical oncologist. So it'll be neoadjuvant sense ACT. So after the AC portion is complete, which is the halfway mark, I
okay,
typically do an objective assessment with an ultrasound. They come and see me every 2 weeks in clinic
okay,
before the next cycle of chemotherapy. They see me in clinic and I do a physical exam where my nurse and I will measure the tumor objectively, feel the axilla to ensure that we're happy that there is some clinical response. And then halfway through, we'll do an objective assessment with an ultrasound, an interim ultrasound to ensure that there's radiographic response.
okay.
It's less than 5% of the time where you will see disease progression in that interim ultrasound, but the vast majority of the time, so more than 95% of the time, the radiographic findings will show that there is indeed a response that correlates to what I've been seeing clinically with the serial visits.
Yeah, I'm often amazed at how, it, tumors respond to the regimens that, you guys put them on. So whatever
It's a
trials
very
that,
gratifying
data you
disease to
have,
treat.
it absolutely
Yeah,
is
it's I
amazing.
yeah, I literally what did one of the other medics in the States say? He said, I slay rogue cancer cells, and it does feel like you're doing that.
Absolutely. Yes. No, it always makes me happy when I see that. Okay, endocrine therapy. What is that?
Yeah. So endocrine therapy is anti-hormonal medicines to suppress estrogen or block the effect of estrogen in the body. And estrogen is very bad for breast cancers, for certain breast cancers, these ERPR positive breast cancers, because it's essentially acting as food or fuel, where it's catalyzing that process and causing the cell to progress through the cell cycle in an unregulated fashion, which is essentially a cancer cell. Cancer cell is a cell that continues to replicate in an unregulated way. Our body needs to stop cell cycle, stop regulation, replication, stop growth. Otherwise, it becomes a cancerous tumor, which is growing too quickly, too fast. And estrogen is a catalyst for this. Progesterone is a catalyst for this. So, what these endocrine therapies do is they decrease the production of estrogen, or they prevent estrogen from binding to the estrogen receptor so it doesn't have an effect in certain tissues, like works that way. And so, these endocrine therapies decrease the chances of the breast cancer coming back by cutting off the food supply for the breast cancer to minimize that effect of estrogen. in the body or decrease estrogen production. As a result, because they're decreasing hormonal production, as women, we have estrogen. We naturally make estrogen from birth until menopause. Our ovaries make estrogen, and these endocrine therapies stop that process. So they stop estrogen production or they block estrogen effects. And as a result, you have side effects of feeling like you're going through menopause, which means
Mhm.
your body is now starved of estrogen. So you are going to have what we call vasomotor symptoms, or symptoms like you are going through menopause. So hot flashes and night sweats. They don't happen in everyone. I find that
Mhm.
it happens in about 50% of women that we start
Mm,
on these endocrine therapies. And the other 50% feel great. They're like, "Are you sure you're giving me the right drug? I feel wonderful. I don't have any of these side
really?
effects."
Okay.
Yeah, so not everyone has these side effects. Like every medicine we take, I guess, not everyone develops side effects to every medicine. And then it can also affect the joints. So that the other thing estrogen does for us is it really lubricates our joints and makes us feel
Mhm.
limber. But these endocrine therapies, because they're decreasing that estrogen production, can cause a lot of muscle aches and pains and joint aches and pains. And then estrogen is very protective for our bones. It helps to enhance our bone production. It helps our osteoblasts make bones. So endocrine therapies can make us more likely to develop osteoporosis or thinning of the bones. So that's the other
Right.
major side effect of endocrine therapies.
Okay, interesting. I was, you were talking about research. I was reading something, I think it's called, and I might be pronouncing it wrong, Velza. It's supposed to be a
Velza.
new drug in the States that is you could use to treat these menopausal symptoms. I might
How's it
be
spelled?
I think it's called VE. It sounds like Yelza, but Vielza. I don't know if you're in front of a computer.
Do you know what the scientific name of it is?
Written it down too at work, and
Oh, is it fezolinetant?
that's it. Yes.
Yeah, fezolinetant. Yeah. We have
Yes.
lots of drugs. So this is one of them. We have lots of drugs that actually treat the menopausal symptoms. So we don't just let these women suffer. If they
Okay.
develop the vasomotor symptoms, we have many medications we can use. So we have
Okay.
Effexor, which is I find the most effective one. So I start the majority of my patients on venlafaxine or Effexor,
Okay.
um, a low dose, and then sort of work their way up depending. And then we also have gabapentin, we have clonidine, we have oxybutynin. So that those drugs help with the vasomotor symptoms of menopause. And then for the arthralgias and myalgias, what's actually been shown to be effective is exercise
Okay.
and acupuncture. Actually,
Mm.
exercise and acupuncture are the two things because it tends to be. I know exercise. It sounds counterintuitive, but
Mhm.
the muscle aches and pains tends to be more of a stiffness. So it's worse in the morning time because we've been lying in bed all night. And it
Mm.
gets better as the day goes on, as you get moving and your joints get active again. And as you exercise more and more, that alleviates that muscle and joint aches and pains.
Okay. Good to know. So those are more for hormone positive tumors. Now for the
Yes, correct.
HER2 positive, the triple negative, what is immunotherapy or targeted therapy?
Yeah. So for HER2 positive breast cancer, the targeted therapy is targeted against that HER2 protein. So we use an antibody called Herceptin. This antibody tremendously changed the way we treat HER2 positive breast cancer, improved survival outcomes tremendously decades ago. So we use HER2 antibodies called Herceptin for HER2 positive breast cancer. We also have new antibodies that are emerging. Pertuzumab is another anti-HER2 antibody that we use in the neoadjuvant and adjuvant setting for HER2 positive breast cancer. And we also have other emerging antibodies like trastuzumab deruxtecan. I have many patients that are on that drug as well. So this is another antibody that's linked to a chemotherapy,
Mm.
something called an antibody drug conjugate. So there's lots emerging for HER2 positive that targets that HER2 overexpressed protein. And we don't use immunotherapy for HER2 positive breast cancer yet as standard therapy, but we do use immunotherapy for triple negative breast cancer. So triple negative breast cancer is a breast cancer that's been shown to be very responsive to immunotherapy. And so we use a drug called pembrolizumab, which
Okay.
is an immunotherapy drug or immune checkpoint inhibitor for early stage triple negative breast cancer and metastatic triple negative breast cancer. Atezolizumab we also use for triple negative breast cancer as well.
Do you find that it's pretty effective?
Yes, I would say that I see very much I see thousands of patients. So I do find that I see very much what's reported in the literature where
Okay.
you'll have the majority of patients will achieve some response to immunotherapy agents given in combination with chemotherapy before surgery. So in the neoadjuvant setting, it results in a lot of tumor shrinkage. You will see some side effects to immunotherapies, but for the most part, the side effects tend to be manageable.
Okay. Awesome. Great. Thank you. You're a wealth of information, Dr. Doreen. This is amazing. Okay. Radiation therapy. Who gets radiation therapy and why?
Yeah, yeah, that's a very good question. So, in early stage breast cancer, radiation therapy is indicated to decrease the risk of what we call local regional recurrence. So, if you develop a breast cancer in your right breast, let's say, and that's removed by surgery, the area where it's got the highest chance of coming back is the area that was in closest proximity to that initial tumor. So, the skin and the soft tissue in the chest wall around the breast, the armpit. Those are the areas where the breast cancer has the highest chances of coming back. So that's the local regional area that radiation is typically given to minimize that risk. Now, as you alluded to, radiation is not given in everyone. Radiation is indicated when there is felt to be the highest chances of the breast cancer coming back. So in patients who receive what we call breast conservation surgery or a lumpectomy, which means they have a surgery to remove the tumor, but there's still breast tissue left behind because they just wanted the lump removed. And so the surgeon may just remove that quadrant of the breast or the tumor and some of the tissue around it to get clear margins, but there's still breast tissue remaining.
Hmm.
So that's called a lumpectomy, or another name for it is breast conservation surgery. So that's when radiation is needed to
Okay.
reduce the risk of local regional recurrence because there's still breast tissue left behind. The other scenario where radiation is indicated is in node positive disease. So in lymph node positive disease, I mentioned earlier that if the first place breast cancer spreads to, once the tumor grows to a point where it's going to spread, is to the armpit on the same side of the breast. And so if if the breast cancer has traveled to the armpit, then radiation is indicated in that scenario
Mm.
because it has been shown to decrease that risk of local regional recurrence in patients with no positive disease or those who have breast conservation surgery.
Okay. Awesome. That's really good to know. Okay. Thank you. You've
Mhm.
explained quite a bit. So I think would it be fair to say patients see surgeons before they come to see you?
Yeah, that used to be our traditional pathway. Now we
Okay.
have this neoadjuvant pathway, and you may have heard, I think it was Malin Kwan speaking
Mm.
about it maybe 6 or 9 months ago, and it just rolled out. So here in Calgary, we have this pathway that helps to expedite things a bit for the patient. And so they will often now, if they are someone who is known to have a larger tumor, lymph node involvement, HER2 positive, triple negative, with a larger tumor and lymph node involvement, they will straight away meet a medical oncologist to talk about chemo before surgery because that is the standard worldwide approach for management of these diseases. If it's a small tumor that's ERPR positive, then they will meet a surgeon first.
Okay. And otherwise they'll do the neoadjuvant pathway. Okay, that's good. I love
Yes,
that. I love
exactly.
our pathways here, our BIRADS 5 pathway. We're also talking
Yes.
about in the quality assurance meeting, sometimes even the BIRADS 5, sometimes I see tumors that are just super fast growing and we want them to
Mhm.
come to the, Calgary Breast Health program like sooner rather than later. So we're
Yeah. I'm
kind of
always amazed when I look at the log. I'm always amazed at how quickly these patients have a mammogram, biopsied. It's reviewed the same day. You guys do a fantastic job in the radiology department. It's
thank
just
you.
phenomenal. I look at the log and I'm like, it's the same day. It's so quick. I love it.
Yeah, it's been a work in
Doing well for
progress
our
for a long
patients.
time. Yeah, like, we
Yeah.
we just try to get them from when they come in to when they see the surgeon to really cut down on that time because, obviously it's
Wow.
it's super stressful, right? So,
Yeah.
okay. Well, I think we've talked about a lot of
Mm.
stuff. We're getting close to the end now. I'm very cognizant of the time.
Oh, yeah.
Now, in Canada, we face some unique challenges that are different from other parts of the world, especially US. And one of the recent ones that I would love us to touch on is the Canadian Task Force guidelines. The states, they went from 50 to 40 for screening, and Canada is still sticking to 50, even though I'm sure you've seen it when they talk about that 40 to 50 age group, they do put in there that the mortality is higher for Black women, but they still keep it at 50, which I feel a very particular way about, and it's not
Yeah,
good, you know? Like,
I know. Yeah.
that bothers me so much because, we're seeing obviously that in racialized women, the breast cancer age peaks, it's an earlier peak than in Caucasian women. So I kind of want to know your thoughts about that and what do you foresee the
Yeah.
future to be?
Yeah. There has been some positive advancement. Now in Alberta, the age is 45. So this was a change in the past couple of 2 years ago, I want to say two, not 3 years ago, 2.5 years ago. So now the screening age is 45. So if you're 45 years old, you can go to your family doctor and ask for a mammogram, and you will be able to get a mammogram at the age of 45. For anal cancer doctors like me, I will probably start at age 40, to be honest. But
Yeah, you
the
can get it
data's
at
there.
40,
The data really
actually.
speaks. You can just request it
Yeah.
and you can get it. So, the data's there. The data speaks volumes as to the benefits of starting screening at the age of 40. Canada, we are very economic minded. And I think we are thinking very much at a population level because of the way our healthcare system is structured, because we are a public healthcare system and the government is paying for all of this. In the States,
Mhm,
if you have money, you can pay. You can go at the age of 20, 30. I wouldn't recommend that. But at the age of 40, you can go. And if
mhm,
you have a good job with good insurance, you can get your mammograms from the age of 40. You can do what the evidence says. In
mhm.
Canada, they are thinking at a population level and they're looking at the cost effectiveness, and that impacts that decision a lot. And that's what I find a lot. It's disappointing. It really is, because we are doing
Yeah.
our population a disservice, and we're doing a particular subset of our population a disservice. Our racialized women, our visible minorities, we're doing them a disservice. And so
Mm.
it's just up to you and I to spread the word and other doctors like us to spread the word that you can start at a
Yeah.
young age. You can start at the age of 45. You can start at the age of 40 to request a mammogram, because we know that we see these diseases and we see the impact it can have on somebody's life and even mortality.
Yeah, I absolutely agree. It is a major disservice. And, on the one hand, we have free health care here, yes. But on the other hand, like you said, maybe that's it. We're looking at population based. We're looking at the economics, and it's a disservice to racialized women,
Yes, it
and
truly is.
I hope that women hear this, especially if you're racialized, and know that you need to come in at 40. Not only is there a disservice, then they talk about what's it, this shared decision making. And unfortunately, we're seeing
Yeah.
some family physicians who don't want their patients to get mammograms at 40. Yeah, we're making some progress. Alberta was actually the first province to go into the 40s, 45. We'd like to see, whereas now some provinces are like Ontario, BC, it's 40. So we're,
Yeah.
we're, we're trying to move toward that direction and take
Mhm.
baby steps, but hopefully we'll get there.
I think we will. I suspect that in about 5 years, we will be down to age 40 for recommendation for screening mammograms. I suspect that. Given the amount of young patients I'm seeing in their 30s, in their early 40s with breast cancer.
So, so there's obviously the access issue, but then we talk about that 42%, 42 to 44% increase in mortality, depending on what source you're looking at. And I wonder, why is that? That's a high number.
Increase in mortality in racialized women.
Yes.
Yeah. And I see this in my practice too. And I would place a lot of the blame on that medical system distrust. I always have to look up if it's distrust or mistrust, where a lot of racialized women, racialized patients in general, do
Hmm.
not trust the healthcare system, and they do not trust the recommendations from the healthcare system. I see more commonly that Caucasians will accept the treatment that's recommended, and they also have that health literacy. Well, they will even go and look up the guidelines. There's Alberta Cancer Guidelines, there's Cancer Care Ontario guidelines, there's ESMO guidelines, there's public guidelines. You can ask ChatGPT these days how to treat breast cancer, and it will say on there, these are the recommendations, that these are the things. And when they
Mm-hmm.
go see their oncologist, their oncologist will say the same information. So they will understand, and they'll even ask me, well, what about pertuzumab? Well, what about this? Can I have this? This is what my Caucasian patients will do, because they
Yeah.
read up on it. But
Hmm.
then you'll have the racialized patients who maybe don't have that health literacy, maybe don't feel empowered to go and look or even to accept the treatments because maybe they are not trusting. It's something that's rooted in a lot of history and a lot of distrust that has happened in the healthcare system in the past. Things have changed decades later, but we are still seeing the reverberating effects of that even decades later. I think that having providers that look like them is very helpful. I find that My patients breathe a sigh of relief when I walk into the room and I
Same.
look like them. They breathe a sigh of relief. They're so amazed that they have a Black oncologist. They can't even imagine, right?
Uh-huh.
And then they're more willing to accept the treatments that I discuss. The other thing, and I don't blame racialized patients, is that we have this issue of underrepresentation of visible minorities of Black patients on clinical trials, on cancer clinical trials. If you look on some clinical trials, if you look at the table one where they break down all the demographics, you'll see 75% Caucasian, 23% Asian, 1%, 2% Black. And so I've had patients, my Black patients tell me, well, why should I accept this treatment if it was only tested on one or three patients that look like me? And it's plausible, right? It's a plausible argument because if your research sample is not representative of the population out there, then that starts to affect the external validity of those results. And so this is something that, I do some work with the Canadian Cancer Clinical Trials Group, and so this is something that we're working on to increase representation of Black patients on clinical trials, because now it becomes a chicken and an egg. Because if
Mm-hmm.
Black patients, racialized patients, do not trust the medical system, the healthcare system, they don't trust clinical trials, the whole infrastructure, then they don't want to enroll on these trials. And so you have
Exactly.
underrepresentation of patients on those trials. And then that perpetuates
It's kind of a
that
cycle.
lack of willingness to accept these treatments because they don't see people that look like them. These treatments weren't tested in people that look in enough people that look like them. Things are
Mm-hmm.
changing. There's been tremendous improvement in prostate cancer. There was like a New England Journal of Medicine paper where they looked at outcomes in Black prostate cancer patients only, and they had something like over 75% Black prostate cancer patients on these trials, and it's amazing. So things are really,
Mm-hmm.
really changing. But this is some of the history as to why we are seeing those differences in survival outcomes in different ethnicities.
Yeah, no, I agree. It's same, when I have a Black patient, there's that, I describe it as it's unspoken, it's just,
Yes.
it's the
Yes.
familiarity, it's home.
Yes.
And yes,
Yes.
and then they are more inclined to do what I recommend, and
Exactly.
yeah, at the same time, I think too that we are in Canada. And so, I grew up in Nigeria. Obviously,
Mhm.
the Caucasian physicians are going to be the minority. And so
Mhm.
here, the Caucasian physicians are going to be the majority, right? And so
Yeah.
I just tell our people it's baby steps, right? To try and trust the
Yeah.
process and do the research, because to not let the fact that, Black physicians definitely were underrepresented, we're the minority, but to not let that keep them from getting the care that they need.
Exactly. Yeah, that's a
That's so
great message to keep
important.
repeating. Yeah. Mhm.
So, what advice would you have for patients and families to navigate difficult conversations around prognosis and treatment? And
I tell people to record the conversation with their oncologist so that they can play it back later. It's often a lot of information that we go through, and this can be overwhelming. I see this deer in headlights look often when they're
hmm
seeing me in clinic and I'm going through all these treatments. You know how a healthcare system is structured. Sometimes I have 45 minutes of a clinic appointment to go through these treatments. And that includes the history and the physical exam and the nursing bits too. So sometimes I have max 20 minutes to go through all this information. It's overwhelming. So I tell them, bring a loved one, a
hmm
caregiver, bring many loved ones because they often have a different perspective, a different lens. They are not the ones physically going through it. So they're a bit removed and they can ask questions because they have a higher level view of everything and record the conversation. And then I tell people, I give them the opportunity after our conversation. What questions do you have? I don't ask them, do you have any questions? I ask them, what questions do you have? I know it's a lot of information. You will have questions. What do you have? What questions do you have? And you will have questions between now and when we meet again. Please write them down and we can go over them at our next visit. And these are some of the ways to help get through this conversation because you step out of the room and you think, what did that doctor say? There was so much
hmm
that I went through, and you lie in bed at night and you think about different conversations that we had and treatment options that we had, and maybe new things come to your mind. So that's why I tell them write it down and then we can discuss it at our next visits. I think these are some of the tools: recording, bringing loved ones, and writing things down to help navigate those discussions. We used to always wear a badge as well, saying "Ask me about clinical trials." Now we have signs all over the cancer center that say "Ask me about clinical trials." So I think all patients should be empowered to ask about clinical trials.
Yeah, no, I think that's a wonderful way to explain what you do and a note to end it on to thank you so much. I mean, like your patient said, you do huge things. And when I hear how you expressed how you thought about how you think about your patients and even crying with some patients, that's human. And I think sometimes people, we're told, oh, you can't cry with your patients. But it speaks to the caliber and quality of person that you are. And I appreciate that, and I'm sure your patients do a lot. So I just really want to thank you for today's episode. There is so much in there. I could keep talking to you for quite a while. And I really want to thank you for what you're doing for cancer care and research and for our people. I hear you, I see you, I feel you, and they do too, and I would say breast cancer awareness, as we get close to October, it's not just about the pink ribbons, right? It's about power and persistence and paying attention. And I think that we can all raise awareness by working together. And I want people to know that whether they're a patient or a loved one or somebody that cares, to remember that you don't need a medical degree to make a difference. You just need their voice, their story, and the courage to share that story. So we want to make as much noise as possible to make a difference and change what's going on right now. So thank you so much. Thanks for being a guest on my podcast, and to everyone that's listened, thank you. I look forward to sharing the next episode with you. Please follow me on my social media platforms at Dr. Ezeife Women's Health for upcoming episodes and more. The discussions and opinions shared on this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.